thank you all for coming to this talk about graft versus host disease, which is one of the life-threatening complications of stem cell transplant that has long been, which is one of the life-threatening complications of stem cell transplant that has long puzzled, yet fascinated clinicians. And it appears, though, that we're entering an era where we're on the verge of a number of major breakthroughs on the horizon, and that's going to be the focus of this talk. And so my disclosures are listed on the slide here. And I'm going to start off with a very brief review, just some updates on the epidemiology, pathogenesis, and the clinical manifestations of acute GVHD, followed by a discussion of the current standards of care with respect to the prevention and treatment of this disease, and then finish off the talk with a comprehensive review of some of the novel approaches that really hold some significant promise with improving our ability to prevent as well as treat this life-threatening complication. And so, despite a number of advances, including advances in supportive care, advances in donor selection, amongst others, GVHD remains the leading cause of non-relapse death in allotransplant patients in both related and unrelated donor transplants. And so conceptually, the success of an allotransplant is mediated in part by the cytotoxicity of the conditioning regimen, but also in part by the ability of donor-derived T cells to recognize and eliminate any residual malignant cells. But unfortunately, these same two constituents also compromise the pathogenesis for GVHD, which simply is an immunologic complication that results from donor T cell mediated attack on several healthy recipient organs. And the incidence of GVHD significantly varies based on a number of risk factors, including HLA disparity, donor source, age of the recipient, age of gender, graft source, and so forth and so forth. And the incidence is somewhere between 30 and 70%. But of all of the risk factors, there is one emerging one that I think holds a lot of interesting promise with respect to moving forward and different therapies that may affect this risk, and that's the composition of one's microbiome. And so the intestinal microbiome is composed of trillions of bacteria that have the ability to critically regulate immune biology. And so potentially affecting the integrity of one's microbiome can significantly affect the possibility of developing GVHD, which obviously has very significant consequences within the context of an allotransplant. And just a few weeks ago, investigators at Memorial Sloan Kettering, in conjunction with some colleagues at a medical center in Germany, published the results of a large retrospective analysis in which they demonstrated that patients that were exposed to broad-spectrum antimicrobials within the first week of their transplant, so it was from day -7 to day 0 approximately, had a significantly increased risk of GVHD, GVHD-related mortality, and thereby worse overall survival, further supporting the association between affecting the composition of one's intestinal microbiome and the possibility of developing graft versus host disease. The pathogenesis of GVHD can be conceptualized in 3 key steps, with the process set in motion by damage imparted by the conditioning regimen, often superimposed on pre-existing damage from either prior rounds of chemotherapy, the malignancy itself, or prior infections. And then this causes the upregulation of recipient antigen-presenting cells, causing the release of various pro-inflammatory cytokines. And then concurrently, patients have donor cells infused. These are alloreactive cells which then interact with activated recipient antigen-presenting cells, causing this vicious cascade of a various number of pro-inflammatory cytokines released, ultimately causing damage to very specific sites, including the gut, the skin, and the liver. The classification of GVH has recently undergone a significant revamp, as historically, GVHD was classified as either being acute or chronic, with the time of onset of symptoms representing really the chronology or the classification of the disease, with day 100 being served as the major marker. But now, GVHD is classified really according to a continuing process. So basically, the symptoms themselves now drive the classification rather than the time of onset. And the reason for the recent change is because up to 50% of patients now are diagnosed with acute GVHD after day 100, and therefore the original classification was missing a large subset of patients. And this recent change in terms of the late acute GVH cases is largely attributed to the rise in the use of reduced intensity conditioning regimens. But unlike the classification of GVHD, the staging and grading of this disease hasn't actually changed all that much since about the mid-1990s with the modified Glucksberg criteria, which you see up on the slide, which basically classifies or basically stages and grades GVHD according to the extent of a rash, the levels of bilirubin, and the volume of diarrhea. Now, I'll readdress this a little bit later on towards the latter part of my talk, because just recently this is starting to be reworked and may have actually some significant implications with respect to initial therapy. And ultimately, the holy grail of GVHD is to reduce GVHD, but not negatively affect the graft versus tumor effect. As I mentioned, these are very closely intertwined, thought to be the same donor cells, and of course, we can augment immunosuppression, which can potentially reduce GVHD, but at the risk of increasing the risk of relapse. And then conversely, we could potentially reduce prophylaxis, which may upregulate or augment the graft versus tumor effect, but at the potential downside of increasing GVHD. So there's a lot of work ongoing right now into being able to identify novel strategies that will allow us to basically reduce graft versus host disease without negatively affecting the graft versus tumor effect. And this leads us to our first audience response question, which is, which of the following statements regarding GVHD is the most accurate? Is it A, acute GVHD only occurs before day 100 following a transplant? B, the most common organs involved in acute GVHD are the skin, the gut, and the liver? C, intensifying immunosuppression has been routinely shown to reduce GVHD and enhance GVL? Or D, chronic GVHD only occurs after day 100 following a transplant? And so almost everyone chose B, which is correct. So A is no longer an appropriate response just because now GVH is classified according to this continual process with the symptom themselves driving the classification as opposed to the time of onset. And then choice C is not correct because certainly by intensifying immunosuppression, we have the risk of mitigating the GVL effect as opposed to enhancing the GVL effect, and then chronic GVHD can occur really before or after day 100. So this leads us to the next portion of the talk, which given the high incidence of GVHD, there's a significant effort ongoing right now, really worldwide, not just nationwide, identifying strategies to help our ability to prevent acute graft versus host disease. And these strategies include various approaches. They include optimizing donor selection, identifying strategies to improve conditioning regimens, possibly depleting T cells from the graft, and then a whole amount of effort is ongoing into being able to improve pharmacologic prophylaxis strategies. So if one was to devise the optimal GVHD prophylaxis strategy, what would be the main characteristics? Well, of course, the strategy or the pharmacologic prophylaxis regimen should have anti-GVHD activity, but importantly, it should not negatively affect the graft versus tumor effect. And in the best case scenario, in the ideal scenario, it should optimize the graft versus tumor effect. And then the regimen should be well tolerated with respect to drug-drug interactions and adverse effects. Now, one of my objectives was to review the standards of care for GVHD prophylaxis. So what are the standards of care? Well, we actually don't have a standard of care, and despite allotransplantation being routinely performed now for 30 plus years, there is still no widely accepted standard GVHD prophylaxis regimen. There are numbers that are used across the world. These include a combination of calcineurin inhibition with a short 4-day course of methotrexate. Some centers have substituted methotrexate with either mycophenolate or sirolimus, but we still don't have a really consensus-based approach to primary GVHD prophylaxis. And just to show the variability in graft versus host disease prevention regimens, a recent survey by the European Blood and Marrow Transplant Group had asked a number of European transplant centers 2 questions. 1, what's your primary prophylaxis strategy for those allografted with a myeloablative conditioning regimen? And 2, for a reduced intensity conditioning regimen. And as you can see, there's significant heterogeneity across the board. Some centers use a calcineurin inhibitor with methotrexate. Others use calcineurin inhibition with MMF. Some actually just use a calcineurin inhibitor alone. And so there are significant disparities with respect to the standards, with respect to the practice of preventing GVH across a multitude of transplant centers. Perhaps the most common used is a calcineurin inhibitor with a short 4-day course of methotrexate. Interestingly, in Europe, cyclosporin is used more often, but in the States, we probably use tacrolimus more. And the reason why in the States we've shifted away from cyclosporin, although some centers still use it, is due to the results of several prospective large randomized phase 3 trials that randomized patients undergoing an HLA-matched HLA-matched sibling donor transplant or an unrelated donor transplant, to either tac methotrexate or cyclosporin methotrexate. And in both trials, those that received tac methotrexate had significantly less incidence of acute graft versus host disease. Interestingly and surprisingly to the investigators, in the patients that were undergoing an HLA identical sibling donor transplant, despite having less GVHD with tac methotrexate, they actually had worse overall survival, which didn't make much sense because there was no difference in relapse risks. And so when the investigators went back into the data set to analyze the or to find a potential reason as to the overall survival difference, what they observed was that there was actually an imbalance in the randomization of patients that had advanced disease to the tacrolimus arm. And so when the data was reanalyzed with an appropriate randomization according to advanced or non-advanced disease status, the survival difference was negated. And so, therefore, at least most centers in the U.S. have now adopted a tacmethotrexate GVH prophylaxis regimen if calcineurin inhibition with methotrexate is what the regimen of choice is for the center. Now, why the added GVH benefit with tacrolimus compared to cyclosporin? Well, it's true that both inhibit calcineurin and therefore inhibit various cytokine productions downstream, but unlike cyclosporin, TAC actually also has the ability to dampen cytokine-stimulated T-cell activity via direct inhibition of IL-2 and via direct inhibition of IL-7, and therefore repolarizing the pro-inflammatory response from Th1 to possibly Th2 type cells. Now, as certainly this audience is aware, calcineurin inhibitors have substantial challenges associated with their routine use. These drugs have a narrow therapeutic index. They have significant variability in their pharmacokinetic profiles attributed to a number of reasons. These include drug-drug interactions, organ dysfunction. These drugs are highly bound to red cells, highly bound to albumin, and so fluctuations in red cells and albumin levels can significantly affect the pharmacokinetics of these agents. And then many of the enzymes that are responsible for metabolizing both TAC and cyclosporin are highly polymorphic, and thus these drugs are at risk for significant differences in the PK profile and then consequently in the trough concentrations that are achieved due to genomic variation. And this is a list of just some of the enzymes that are associated with calcineurin inhibitor pharmacokinetics. This is not an all-inclusive list, but just some. And all of these are highly polymorphic. Many of these have significant gene variants that can significantly affect the pharmacokinetics of these agents and then thereby potentially affect trough concentrations and thereby potentially affect clinical outcomes. And so to investigate the association between polymorphisms of tacrolimus or cyclosporin and concentrations of these drugs in BMT patients, one of the first groups to do this was a group in Japan in which they conducted a retrospective analysis testing a number of different gene polymorphisms associated with a number of different isoenzymes, many of which I showed you on the previous slide, and then studied the associations between these gene variants and initial concentrations of both tacrolimus and cyclosporin in 58 patients undergoing myeloablative conditioning transplant. And of all the isoenzymes that they evaluated, the most pertinent was genomic variation in CYP3A5, which has long been known in renal transplant and liver transplant patients, but more recently now reproduced in the BMT population. And they had identified two specific genotypes that significantly alter the pharmacokinetics of cyclosporin, and then two that significantly alter the pharmacokinetics of tacrolimus. And these polymorphisms basically cause the functional capacity of CYP3A5 to be significantly changed. And there's a subset of patients that end up being not true hypermetabolizers, but having significantly lower initial trough concentrations of drugs. And why this is important is because there was pre-existing preclinical evidence that suggested that the initial sequence, the initial immunologic sequence of graft versus host disease starts within the first few days of a stem cell transplant, even if symptoms don't manifest for many weeks and sometimes months post-transplant. And so thereby, potentially, patients who have a genomic variation leading to lower initial trough concentrations of either cyclosporin or tacrolimus may be predisposed to a higher risk of graft versus host disease. And this hypothesis caused our group to actually evaluate this notion. And in a retrospective cohort analysis of 120 consecutive patients who were allografted with fludarabine busulfan, a uniform reduced intensity conditioning regimen, which is the most common reduced intensity conditioning regimen used according to the CIBMTR, all these patients received standard TAC methotrexate for GVHD prophylaxis. And we basically looked to see, does lower TAC concentrations, or do lower TAC concentrations predispose patients to a higher risk of graft versus host disease, especially lower TAC concentrations early on in the transplant course? And what we found was that lower week 1 TAC concentrations were actually independently predictive of a higher risk of GVHD. And then to further characterize this association, we separated the groups into tertiles and found that patients with a mean week 1 TAC level of less than 12 had about a 50% relative risk increase in developing GVHD compared to those with a mean week 1 TAC level of greater than 12, at least in this patient population. Now, there's also been a push to identify strategies for a methotrexate-free immunosuppression regimen. And why methotrexate-free? Because certainly, as this audience is aware, methotrexate has significant toxicities. The main dose-limiting toxicities of methotrexate when used at the doses for GVHD prophylaxis are mucositis, and then to a lesser extent nephrotoxicity, pleural effusions can happen. And then, due to its cytotoxic nature, it can delay engraftment. The two most common strategies that have been utilized as a way to replace methotrexate in combination with a calcineurin inhibitor have been to replace methotrexate with either MMF or mycophenolate, which has the theoretical advantage of leading to faster engraftment and less mucositis, or sirolimus, which has the theoretical advantage of upregulating regulatory T cell activity. And we know regulatory T cells are critically important in mediating the graft versus tumor effect. And sirolimus also does not cause nephrotoxicity in most patients, unlike methotrexate. And so there have been a lot of studies that have compared methotrexate-based GVHD prophylaxis versus MMF-based GVHD prophylaxis, with results really quite variable. And the inconsistency can be attributed to a multitude of reasons, and these include heterogeneity in the patient population studied, variability in the dosing of MMF, and so forth and so forth. And thus, to address the question of what really is the comparison between methotrexate versus MMF-based GVHD prophylaxis, a large meta-analysis was done a few years ago, which included 11 trials, 3 randomized, 8 non-randomized. And basically what the investigators found was that there's no difference in the overall incidence of acute GVHD. However, patients that got MMF-based prophylaxis did have a higher incidence of grades 3 to 4 GVHD, which is really the life-threatening feature of this disease, and really the grades of GVH that we worry most about, because these are the patients that are really the most difficult to treat. Yes, MMF-based GVHD prophylaxis did lead to less mucositis and a faster time to engraftment, but at the potential expense of a higher risk of severe graft versus host disease. But importantly, what these trials did not evaluate was the variability in MMF kinetics. And there are a number of reasons as to why mycophenolate kinetics can be quite heterogeneous across different patient populations, and these include genomic variation, absorption, and so forth. And so to study the association between the primary active metabolite of MMF, which is mycophenolic acid, or MPA, and the risk of GVHD, the group at University of Washington, in conjunction with the Fred Hutchinson Cancer Center, studied over 300 reduced-intensity conditioning transplants that were conditioned with either TBI alone or TBI with fludarabine, and received either TAC or cyclosporin with MMF for primary GVH prophylaxis. And then they utilized this effective increasing mean total MPA concentration in steady state as really the endpoint, as the primary variable of interest, and evaluated a number of outcomes related to the mean total MPA concentration steady state. And what this group observed was that in unrelated donor transplants, patients who had lower mean total MPA concentration steady state by day 25 post-transplant had a significantly higher risk of severe graft versus host disease and worse non-relapse mortality. There really didn't appear to be a strong association between MPA concentrations and GVHD in related donor transplants, but certainly in unrelated donor transplants, the findings were quite compelling. And then just recently, within the last year or so, the group at Memorial Sloan Kettering, led by Stephen Harnaker, conducted a similar analysis using some different endpoints and using a different technique, and this in umbilical cord blood transplant patients, in which they studied 85 patients undergoing cord blood transplant, receiving a CNI MMF-based GVHD prophylaxis regimen, and they collected weekly MPA trough levels for the first 6 weeks post-transplant. And what they found was that patients who had a lower mean week 1 and 2 trough level had an increased risk of severe acute GVHD, not significant, but numerically compelling, without a negative effect on myelosuppression or GI toxicity. And I think the findings of this trial are really quite important and important to reiterate, just because MMF truly is the standard of care for GVHD prophylaxis, at least for cord blood transplantation. And thus, we're learning more and more with some of the data I showed you and some other data I just haven't been able to show you because of the time constraints of this talk, that variability in MMF kinetics can significantly impact outcomes in both cord blood transplant patients, and it appears in unrelated donor transplants as well. And then just like with MMF, TAC has been combined with sirolimus and compared head-to-head versus TAC and methotrexate in a large phase 3 multi-center randomized trial. This is TAC sirolimus has been a regimen that's been devised by the group at Dana-Farber, and they conducted this trial in HLA match-related myeloablative conditioning transplants. And what they observed was no difference in the risk of acute graft versus host disease between the two arms, but faster time to engraftment with sirolimus-based prophylaxis. However, at the expense of a higher risk of VOD and a higher risk of thrombotic microangiopathy, two rare but life-threatening complications of stem cell transplant patients. And these findings have really given some pause to a number of centers from adopting tacrolimus as a standard of care option for patients undergoing a myeloablative conditioning allotransplant. And just like the story with tacrolimus, there are a number of isoenzymes responsible for sirolimus kinetics that can significantly affect sirolimus concentrations. And so to evaluate the influence of genetic polymorphisms on tacrolimus in patients that are receiving this dual regimen approach for GVH prophylaxis, the group at City of Hope studied the association between various polymorphisms and concentrations of both tac and sirolimus in 177 allotransplant patients, and they checked drug levels weekly, multiple times a week, for each of these two agents, and found that just like what's been known with tacrolimus, genetic polymorphisms in CYP3A5 significantly influence tac levels, but importantly, also identified that significant polymorphisms in the ABCB1 gene, which is a gene that codes P-glycoprotein, can significantly affect sirolimus kinetics and significantly affect sirolimus levels. And then taken together, the biggest take-home point of the study was that when taken together, patients who had genomic variation in their CYP3A5 isoenzyme, basically patients who were homozygous for STAR3, leading patients to have basically faster CYP3A5 activity and thus lower levels, had a significantly increased risk of graft versus host disease compared to patients who were not the AA genotype or the STAR3 genotype. And this is further data showing the importance of genomic variation, not just on the pharmacokinetics of these drugs, but actually on clinical outcomes in these patients who receive these therapies for GVHD prophylaxis. And this leads us to our second audience response question, which is, SR is a 48-year-old male with AML and CR. After induction with 7 and 3, followed by 3 cycles of high-dose ARC, he's scheduled for an allogeneic transplant from a 10 out of 10 sibling donor. His myeloablative conditioning regimen consists of busulfan and cyclophosphamide. And so which of the following is the most appropriate GVHD prophylaxis regimen? Is it A, tac methotrexate MMF, B, cyclosporin methotrexate MMF, C, tac methotrexate, or D, sirolimus methotrexate? All right, so most people chose C, which is the correct answer, at least with respect to this question in this patient case. So despite the aforementioned mainstays of therapy, whether your centers use cyclosporin or tacrolimus with methotrexate or with MMF or sirolimus or maybe post-transplant Cytoxan, the incidence of GVH still remains unacceptably high. And clearly we need new therapies that are well tolerated and reducing, and that have the capability to reduce the risk of GVHD further. And as I mentioned with my first slide, I feel like we're actually at the precipice of several significant advances with really new, innovative concepts that I think may significantly impact the probability of patients getting GVHD on a large scale. And I chose a few of them to focus on for the latter part of the talk, and I apologize for any that I may have missed that you guys may be working on or that your institution may be working on, simply with the sake of time, and this being a 50 to 55-minute presentation. I can't mention all the great work that's being done with all the different types of strategies, but the 5 that I wanted to focus on are: one is a strategy that's focusing on targeting the trafficking of lymphocytes away from the target organs of GVHD. Another is really the incorporation of proteasome inhibition with bortezomib due to its pleiotropic effects on B and T cell suppression. We'll also spend some time talking about the notion of post-transplant Cytoxan, which is gaining a lot of steam and a lot of different interests in not just haploidentical transplants, but in related and unrelated transplants as well. And Cytoxan promotes graft-host tolerance via various mechanisms. I'll spend some time talking about T-cell depletion, which is actually not novel, but there are some newer strategies that are being developed and studied in large-scale trials. And then I'll finish off this section with a brief mention of some novel anti-cytokine therapies that are in development as well. And so of these, I wanted to just start off by briefly mentioning the possible role of utilizing a drug, Maraviroc, which many of you are familiar with, which has long been FDA approved for the treatment of HIV. It's a CCR5 antagonist. CCR5 is one of the mediators of HIV entry into T cells. Why in GVHD? Well, CCR5 actually also mediates lymphocyte trafficking to the gut and to the liver, 2 of the 3 key target organs of acute graft versus host disease, and really 2 of the most problematic to treat. And thus, the hypothesis is that if we can utilize a drug that inhibits CCR5, we may potentially prevent T cells from trafficking to the gut and to the liver. And so Ron Reshef, when he was still at the University of Pennsylvania and is now at Columbia University, he devised a phase 1/2 single-center trial of 38 patients undergoing a reduced-intensity conditioning transplant from either a sibling or unrelated donor. All patients received standard tacmethotrexate plus Maraviroc that was initiated on day -2 and continued until day +30. The first 7 patients received 150 milligrams twice daily, and then when no toxicity issue was observed, the remaining patients received the standard FDA-approved dose of Maraviroc for HIV, which is 300 milligrams twice a day, with the primary endpoint being incidence of grades 2 to 4 GVHD by day 100. And impressively, the rates of acute GVHD by day 100 were fairly low at 15% with this 3-drug regimen, but most notably, there were 0 cases of GVH involving the GI tract or the liver by day 100, which is really quite remarkable, with a corresponding low incidence of severe GVHD at around 3%. And then when this 3-drug regimen was compared to a contemporary control arm of just tacmethotrexate without Maraviroc, the incidence of GVHD, both grades 2 to 4 and grades 3 to 4, were lower than with the addition of Maraviroc. The group at Dana-Farber has all pioneered the possibility of using bortezomib to prevent GVHD, and bortezomib has some pleiotropic effects in regulating B and T cell activity, T cells importantly obviously in GVH. Bortezomib can selectively deplete proliferating alloreactive T lymphocytes, may potentially reduce Th1 type cytokines, and may repolarize Th1 type cytokines to Th2 cells. And then in a phase 1/2 single-center trial of 45 patients that underwent a reduced-intensity conditioning transplant for mismatched unrelated donor transplants, all patients received standard tacmethotrexate plus a single dose of bortezomib on days +1, +4, and +7. The incidence of grades 2 to 4 GVHD by 6 months from transplant was low at 22%. And this is quite impressive given the donor status. These are patients who all had mismatched unrelated donor transplants. The risk of GVHD is upwards to 60 to 70% in those undergoing a transplant from a mismatched unrelated donor, and so the 22% incidence here is really quite remarkable. And then Johns Hopkins has been pioneering the use of Cytoxan administered post-transplant for GVH prophylaxis for many years now, first in haploidentical transplants and now being incorporated more and more in standard related and unrelated donor transplants. And Cytoxan has several mechanisms by which it can prevent GVHD, or at least is thought to prevent GVH. It's thought to selectively allodeplete proliferating donor T cells if administered within an appropriate time frame. In this case, it appears that administering Cytoxan on days +3 and +4 post-transplant appears to be the most favorable. And in a phase 1/2 single-center trial of 117 patients who underwent either an HLA-match-related or unrelated donor transplant with BUSI conditioning that received only Cytoxan alone without any other immunosuppression, at 50 milligrams per kilogram, the incidence of GVH was fairly low, or fairly acceptable, we'll say, at 42% in related donor transplants and 46% in unrelated donor grafts, respectively. So where does this lead us? We have 3 really innovative concepts with impressive, at least single-center, small-scale studies with the addition of Maraviroc or bortezomib to tacmethotrexate, and then possibly using Cytoxan post-transplant. So there's currently a randomized phase 2 trial that's ongoing, led by the Blood and Marrow Transplant Clinical Trials Network. The trial is randomizing patients between the ages of 18 to 75 with any disease, with any donor, to either one of 3 arms, either tacmethotrexate Maraviroc, tacmethotrexate bortezomib, or Cytoxan administered post-transplant in combination with TAC and MMF. And there's a contemporary control arm. It's a non-randomized arm of patients that are just receiving tacmethotrexate, and this is really the control arm with the primary endpoint of GVHD or relapse-free survival on 1 year post-transplant. Now, you may be wondering, why is Cytoxan here being administered in combination with TAC-MMF when I just showed you that on the previous slide that Cytoxan alone actually leads to a fairly impressive incidence of graft versus host disease without the long-term complications of administering or co-administering with tacrolimus or any other agent? Well, because what we've recently learned is that Cytoxan administered as sole GVH prophylaxis appears to be acceptable in those receiving bone marrow grafts. But in patients who receive peripheral blood stem cells, actually have an unacceptably high rate of graft versus host disease if receiving post-transplant Cytoxan alone without any co-administered therapies. And in this trial, all patients are receiving peripheral blood stem cells. Therefore, Cytoxan is being co-administered with TAC and MMF. And just to highlight how much excitement there is nationwide with this clinical trial. This trial has been the fastest accruing trial in BMT-CTN history. The trial has finished accrual. It finished accrual probably a year in advance of schedule, and results are expected within the next few months. And hopefully we'll know, at least in those we'll know possibly in those undergoing reduced intensity conditioning transplants, if any of these innovative concepts are superior to the standard TAC methotrexate approach. The other strategy where there's been a lot of work done by Memorial Sloan Kettering and some other groups is to improve our ability to perform T-cell depleted transplants. So T-cell depletion is not new. It's not novel. It's actually been done since the mid-90s. The issue with T-cell depletion is that although it can significantly reduce the risk of graft versus host disease by removing T-cells, you significantly basically remove one of the main drivers of GVHD pathogenesis. But concurrently, at the risk of removing one of the two main reasons as to why transplants are successful, and that's the ability of donor-derived T cells to basically attack any residual malignant cells via the graft versus tumor effect. And so there are different ways to deplete T cells from the graft. There are in vivo techniques which include using drugs like ATG or Campath, and then there's ex vivo techniques as well. There's a T cell subset depletion approach, there's CD34 selection approach, and of all these, there seems to be significant improvements in T cell depletion with respect to not potentially harming the graft versus tumor effect and thereby not significantly increasing the risk of relapse, at least in small studies, if using the CD34 selection approach, because by using CD34 selection, you can eliminate T cells from the graft, but without affecting some of the other cells that, like natural killer cells and cure ligands and so forth, that can mediate the graft versus tumor effect. And therefore, the potential advantage in theory is that with CD34 selection, there will be less GVHD without an increased risk of relapse. Although we don't have large-scale prospective randomized clinical trial data to show that at this time. What we have is really small trials that are done at various centers. But to investigate this strategy further, there's an ongoing randomized phase 3 multicenter trial evaluating two different novel strategies versus what the quote-unquote standard is in this trial. This is a trial that's enrolling patients undergoing a myeloablative conditioning transplant for either AML or MDS up to the ages of 65. Patients enrolled in this trial have to have an HLA-matched donor, and patients are being randomized to either the control arm, in this case is TAC methotrexate, or post-transplant Cytoxan alone without any other immunosuppressive therapy, which is, again, quite innovative because if we can potentially prevent our patients from needing several weeks of MMF or sirolimus or months of tacrolimus, that can really be a significant advance in this field. And the third arm is CD34 selection, actually removing T cells completely without any post-transplant immunosuppression. And as long as the relapse rates aren't markedly affected, this could really be an innovative approach as well. So two large-scale ongoing trials led by the Blood and Marrow Transplant Clinical Trials Network currently evaluating a lot of these innovative novel approaches to help prevent graft versus host disease. And finally, I just wanted to finish off the prevention section by briefly mentioning some really compelling results that were presented just a few weeks ago at the annual BMT meetings in Orlando using tocilizumab. So a number of sessions during this conference have talked about tocilizumab, mostly for the treatment of either HLH or cytokine release syndrome, but tocilizumab is an IL-6 receptor monoclonal antibody which has been FDA approved for several years now for the treatment of rheumatoid arthritis and some other indications. Why IL-6 targeting in GVHD? Well, IL-6 receptors are found in very high levels in the gastrointestinal tract of mice, and thereby potentially preventing IL-6 receptors expression in the GI tract, we may potentially reduce the risk of gastrointestinal GVHD. And then IL-6 receptor can also modulate Th1 and Th17 cells, which are basically the precursors to various pro-inflammatory cytokines associated with graft versus host disease. And so led by Bill Drobisky from the Medical College of Wisconsin, who's the group that's really pioneered the notion of using tocilizumab for graft versus host disease, in a phase 2 trial involving 35 allotransplant patients that received either a related or unrelated graft, received standard TAC methotrexate plus a single dose of tocilizumab at 8 mg per kg, which is the standard dose used for rheumatoid arthritis, just on day -1 post-transplant. So standard TAC methotrexate with just a single dose of tocilizumab. As you can see by the patient characteristics, most were older, most had acute leukemia, most received peripheral blood stem cells, and were conditioned with a variation of fludarabine and busulfan. And impressively, at day 100, the rates of acute graft versus host disease were quite low at 12%, and the incidence of severe graft versus host disease was really low at 3%. But most importantly, I think most notably, was that there were no cases of lower GI GVHD. with the addition of tocilizumab, which again, GI GVHD, especially severe GI GVHD, is really one of the biggest killers with respect to GVHD-related mortality. And then when compared to contemporary controls that were obtained from the CIBMTR in patients that received only tacmethotrexate, the addition of tocilizumab resulted in lower rates of acute GVHD by day 180 from transplant and improved GVHD-free survival, further supporting the possible role of tocilizumab in the prevention of graft-versus-host disease. And so I'm going to finish off the talk with just a brief discussion of some of the treatment options we have for graft-versus-host disease, because despite a lot of the work that's ongoing, up to 70% of patients, depending on various risk factors, still get graft-versus-host disease. And despite a lot of the novel concepts that are being developed to help prevent graft-versus-host disease, the treatment of GVHD hasn't actually changed all that much, as mild cases of skin or gut are treated with topical steroids, whereas most other cases require prolonged courses of high doses of systemic steroids, which aren't terribly effective, with response rates ranging somewhere between 50 and 60 to maybe 70%. But unfortunately, only a third of patients actually have a durable response where they don't need any other immunosuppressive therapies after steroids. And furthermore, certainly as this audience is aware, prolonged courses of high doses of steroids predispose patients to a large number of various short and long-term complications that become really life-threatening in nature for a large portion of patients. So what's being done to help improve our ability to treat GVHD? Well, there is a lot of effort ongoing right now into identifying strategies that can help predict how well someone is or how likely someone is to respond to initial therapy with steroids, basically just with steroids alone. And so there are two main methods that are currently being studied. One is focused on revamping the grading of GVHD and then utilizing a grading technique to help predict or choose initial therapy for patients. And the second strategy is actually using biomarkers to help predict how likely someone is to respond to initial therapy with just high doses of steroids alone. And so led by the University of Minnesota, they've basically revamped the quote-unquote traditional modified Glucksberg criteria. And what they did was they completed a large retrospective analysis in over 1,700 allotransplant recipients and then studied the associations between GVHD clinical stage and the initial response to high dose of steroids at the onset of diagnosis. And then utilize the responses to come up with two risk categories, standard risk and high risk. So basically, patients are grouped into the standard risk criteria if they have single organ involvement consisting of only skin or stage 1 or stage 2 GI, or have two organs involved, skin plus either mild GI involvement or skin plus liver involvement. And all other cases are grouped to be high risk. So as you'll notice, all patients with advanced GI GVHD are considered to be high risk. And what the University of Minnesota found was that patients who have high risk GVHD, according to this revised severity criteria, they are less likely to respond with just steroids alone. And most importantly, they have lower overall survival. And then, led by a group that was initially at University of Michigan and they're now at Mount Sinai, they've actually developed a proprietary-based blood test that can actually test three biomarkers, TNFR1, ST2, and REC3 alpha, and utilize these three biomarkers, which are really markers of inflammation in various sites, and are able to predict how likely one is to respond with just steroids alone for newly diagnosed graft-versus-host disease. And they did this via prospective study in which they collected plasma from almost 500 allotransplant recipients who were newly diagnosed with graft-versus-host disease and received steroids alone as initial therapy. And then, utilizing a proprietary algorithm that they have, they then grouped patients according to their biomarker scoring into one of three criteria using this Ann Arbor GVHD scoring system. So patients had an Ann Arbor score of 1 if they were low risk, they had an Ann Arbor score of 2 if they were moderate risk, and an Ann Arbor score of 3 if they were high risk. And as you can see from the slide, the response to steroids alone for newly diagnosed GVHD significantly varied based on their Ann Arbor score. So upwards to 86% of patients with low-risk disease, according to this biomarker stratification, responded completely to steroids by day 28 of initial therapy. The numbers dropped to 67% if they had moderate risk disease, and then for patients for high risk disease, had less than 50% probability of actually achieving a complete response within the first month of just steroids alone. And then again, most importantly, these biomarkers significantly predicted non-relapse mortality as well as the probability of developing graft versus host disease. So we have these two innovative concepts of stratifying patients in terms of predicting how likely they are to respond to initial therapy for newly diagnosed GVHD with just high doses of steroids alone. And what's being done to move forward in terms of investigating how applicable these stratification criteria can be is there are two ongoing prospective trials that perhaps a number of your centers are participating in where patients are being risk stratified according to whether they have standard risk disease or high risk disease. And there are different interventions within each of these trials. So for patients who have standard risk disease according to the University of Minnesota criteria and an Ann Arbor score of 1 or 2, according to the blood-based biomarker test, there's a randomized phase 2 trial ongoing that's randomizing patients to either prednisone or sirolimus. And the rationale for this trial is that since over 50% of patients are likely to respond to initial therapy for GVHD based on their risk category, perhaps we can avoid the long-term as well as some of the short-term complications of high doses of steroids with perhaps a more safer therapy. And I say this not in the context of actually prospective randomized data, but that's the rationale that perhaps sirolimus may be equally effective, maybe more effective, we don't know, but perhaps safer and less toxic than prednisone administered for months in these patients. And then for patients who have high risk, who are high risk according to their Ann Arbor score, there's an intervention trial, which is a multi-center trial that's only a single-arm trial in which patients are being treated with steroids plus natalizumab. So natalizumab is an integrin inhibitor that's used for autoimmune diseases, and integrin is thought to mediate T-cell trafficking to various GVHD organs. And so the rationale for this trial is that less than 50% of patients are likely to have an adequate response with steroids alone, and therefore they may benefit with augmenting immunosuppression. And so the investigators in this trial have chosen natalizumab. Now, this is a non-randomized study, so how prednisone and natalizumab compares to prednisone alone will be hard to tell, but we'll see as the results come forward within the next year or so as to stratifying initial treatment of GVHD according to the risk using these two innovative concepts, either stratifying according to organ severity or this blood-based biomarker test improves patient outcomes. And then of all of these different aspects of GVHD, perhaps the biggest unmet need is the treatment of steroid refractory graft versus host disease. And there are a number of varying definitions, but for the most part, we think of steroid refractory GVH as either getting worse after 3 days of initial therapy or not getting better after the first week of therapy, and therapy meaning 2 mg per kg per day of steroids. Unfortunately, we don't have any well-defined second-line therapies. There really is no standard of care due to the high failure rates that a number of drugs that are used in this setting. And unfortunately, whatever regimens have been utilized in the second, third, fourth line setting for patients with steroid refractory graft versus host disease, the long-term survival is really quite dismal, with survival rates at best up to 30% and to a far lesser degree in a sizable percentage of patients. And this is a table that I'm not going to spend a lot of time on, but I did want to just put in for completion's sake. This is not an all-inclusive table, but at least includes a large number of treatment options that are used for steroid refractory acute GVHD. Different centers have different criteria for how they choose these types of therapies, but basically, most commonly ATG, Campath, both have been used with varying results. Pentostatin has been used, MMF, sirolimus, and some others. But the real take-home point is in the outcome slide, or in the outcome section of this table, is that for the most part, these agents are associated with maybe a 25, maybe a 50% response rate at best, but with really poor long-term overall survival, as inevitably many of these patients will end up relapsing with these available therapies, and therefore really do need improved treatment options for managing patients with steroid refractory graft versus host disease. And so there are two really interesting concepts that are currently in development. One is the use of ruxolitinib to treat patients with steroid refractory graft versus host disease. So ruxolitinib is an FDA-approved drug, initially approved for the treatment of myelofibrosis and more recently for the treatment of PV. It's a JAK1/2 inhibitor. The main toxicities of ruxolitinib are blood counts dropping as well as infections. Why JAK inhibition in GVHD? Well, specifically JAK1 is actually a critical mediator of the release of various pro-inflammatory cytokines, including IL-2, IL-6, IL-12. These are really the traditional cytokines associated with graft versus host disease pathogenesis, and therefore, therefore potentially inhibiting JAK1 and JAK2 with this agent, since it inhibits both JAK1 and JAK2, we would potentially reduce the risk of GVHD via targeting or via down-regulating these pro-inflammatory cytokines. And recently, a retrospective survey was published that came out of 19 transplant centers in the U.S. and in Europe, in which patients with acute graft versus host disease, as well as some with chronic GVHD that both were refractory to steroids, were treated with ruxolitinib at varying doses, somewhere between 5 and 10 milligrams twice a day. And specifically in those with steroid refractory acute graft versus host disease, there were 54 patients treated, all had grades 3 or 4 GVHD. This is, again, these are the patients who have really life-threatening graft versus host disease, who are expected to live maybe somewhere between 3 and 6 months at best. And these were heavily pretreated patients with a median number of prior therapies being 3. And with the use of ruxolitinib, the CR rate was about 46%, but most notably, 79% of patients were alive at 6 months after initiating ruxolitinib, which is really quite impressive given the high-risk nature of these patients. Furthermore, the time to response was quite quick, with the median time to response being somewhere between 1 and 2 weeks, with the median being 1.5 weeks. And then, with respect to tolerability, the most common toxicities were cytopenias and CMV reactivation. And then this agent appears to have impressive activity for the treatment of steroid-refractory chronic GVHD as well. And then because of this data and some other data that has come out, the FDA has recently granted breakthrough designation for ruxolitinib for the treatment of graft versus host disease. And there's an ongoing registrational trial that's actually evaluating this agent for the treatment of steroid-refractory GVH. And potentially, we may have a new option available within the next few years if the data pans out. And then I'd like to just finish off with a brief mention of tocilizumab again. I've mentioned the rationale for using tocilizumab earlier for GVHD via its inhibition of IL-6 receptor capability, which again is an important pathogenesis or important marker of GVHD in the GI tract. And initially led by the group at Medical College of Wisconsin, they administered tocilizumab as monotherapy for the treatment of steroid refractory graft versus host disease to 8 patients, and there were a few responders. What they observed was that all responders had GI involvement. The group at Ohio State and then our group at Penn had also had some impressive results for with using tocilizumab specifically for patients with GI GVHD, and it doesn't appear to be effective in those who have liver or skin involvement, but specifically in GI, specifically in GI GVHD, the initial data, at least in small numbers, but initial data is quite compelling. And so more to come in the near future with using this agent as well as ruxolitinib for the treatment of steroid refractory graft versus host disease. And the final audience response question is, which of the following novel approaches to GVHD prophylaxis works by preventing lymphocyte trafficking to visceral organs involved in acute GVHD? Is it A, Maraviroc, B, bortezomib, C, cyclophosphamide, or D, ibrutinib? All right, so almost everyone chose A, and it's Maraviroc, which inhibits or prevents T-cell trafficking to the gut and to the liver by inhibiting CCR5, which appears to be an important mediator of T-cell trafficking to the visceral organs involved with graft versus host disease. So, in summary, despite a lot of advances in stem cell transplant over the last 10 to 15 years, GVHD remains the leading cause of non-relapse death in these patients, and therefore, developing novel strategies that are safe and effective remain critically important to help prevent and treat GVHD and remain critically important for successful allo transplant. So that completes my talk, and I'm happy to answer any questions you may have. Thank you all very much.